Hello.
Hello.
Hi, मानसी का?
हो मानसी बोलते, बोला ना.
नाही नुसतं ते चेक करतोय.
हा, हे जे तुम्ही सर रे चौधरींचं म्हटलं ना, she doesn't seem to have connected the audio.
ती मला वाटतं नंतर कनेक्ट करेल. हे माझ्याकडे आहे ना एकच स्लाइड होती. एक मिनिट मी फक्त पटकन शेअर कर.
शुअर मी स्क्रीन शेअर स्टॉप करते, मग तुम्हाला करता येईल तुमचं. Oh yeah, now we have Dr. Ray Chaudhuri also on the line.
I am not able to share my screen yet.
So I using...
झालं.
Yeah.
Hello. Yes.
Yeah, so this is his CV which you are going to introduce him from.
Yeah. And then once I am done introducing, I'll just stop the share and Ola will take over, right?
Yeah, exactly. You can do that. Yeah, we'll also have to talk to her in case if she has any videos to share, then she'll have to do a small setting.
त्यांचा नंबर मी तुम्हाला सांगू का? म्हणजे त्यांना फोन करून हे चालू करायला सांगू?
Talk to them right here, no?
I am online now. The webinar will begin soon. Fine night. Let me just call her, no? Because she doesn't seem to be able to hear us.
Sure. Oh, all right.
Hi Ola, are you still getting that message? Because we are logged on and seem to be doing fine. Are you still getting that message that you sent me? Can you try logging out and logging in again? Because me, the technical person, and Dr. Kothari sir, we are already in the meeting and we seem to be doing fine.
কাজ করবি ওটা নিয়ে ওটা দেন আমাকে এনে তুমি যেটা হারিয়ে যাবে এটা সাউন্ডটা ভালো আসছিল কান থেকে বেরিয়ে যাচ্ছে আচ্ছা এটা বন্ধ নাও করে দিটা বন্ধ নাও তো মিটিং করবে হ্যাঁ
It still says that.
Yes.
They're still getting a message saying the webinar is going to start soon.
That is because she has logged in from the attendees. I haven't broadcasted. We're still only panelists here. It's not open to all the attendees
But
yet.
she should have been able to log in, right? Using the panelist account.
Who you're saying?
Ola. Ray Chaudhuri secretary.
Yeah, but that link it will go only to Dr. Ray Chaudhuri's email ID. And
Ola, you're.
But I am assuming that they have used right now is through the same.
Can you open the? Are you opening the link that was sent on Ray's email account?
He is not at all a teacher.
Right. No, yeah, exactly. The link sent for fellows is only for attendees. They will get a.
Yeah, we have two Ray Chaudhuris over here.
Dr. Ray Chaudhuri's email and you can open it directly from there.
Hello,
sir.
Hi. Broadcast karte, it is 8:20.
Yeah. And doctor, this one also has to त्याला कल्याण भट्टाचार्यला panelist आणि चारू Shankla. So don't send the panelist invitation now. We can.
No, Charu Shankla I've already sent. So
great. Are you able to hear me now, Ola? Oh, there's. Hello, Dr. Chaudhuri.
Hi, Ray.
Hi there.
Hi.
So think we're all set up properly.
Where's Siddharth? I don't see Siddharth.
Sorry, I'm here. I just need to start my
Okay.
video.
Okay, now I see you.
Ah, Sid is here. Sid, hello. How are you, sir?
I'm good. I'm good. How are you, Dr. Chaudhuri?
I'm fine. You look like a minister.
Like a minister.
I don't know if that's a good thing or a bad thing, but I'll take it as a compliment.
He's a bit of both.
Is this good, Dr. Chaudhuri? Do you want me to say something more?
Message saying Pramod was asking whether we are being paid or not.
I think Dr. Kothare will be the right person to answer that.
Who's Pramod? Ah, Pramod. Yeah, I wrote nobody is being paid.
Good idea.
The email only I had written when we invited that, just now it's all pro bono, but in the long run, we should be able to get some sort of pharma support,
I think it's best to keep it academic,
I
as
think
much
so.
as
It's
possible.
safer. Then they don't have any say. They can't interfere. Better.
Exactly. Yeah. So I'm happy to go whenever.
I think we're 6 minutes away, sir.
5-6 minutes more, so people will be
Okay,
joining.
fine. That's fine. I'll just.
Most people jump in last minute, so.
Yeah, that's fine. That's absolutely fine. I'm just. It seems like it's working. So.
You checked the. Did you check you have any videos?
I have a few videos. I'm trying to see if I can share.
Yes. So what
I'll stop share. I'll do that.
Ray, what you have to do before you share the video, you have to. There is a button at the bottom. When you click the share screen, before that, you have to click optimize for full video. You must click that checkbox.
So can I try that now?
Yes, try it. I think so. So first click the shares.
Okay.
Share button.
Yep. And
Kallyan, why have you joined as Ray Chaudhuri?
Because
Yes,
he
I am
has
here.
used the same link. Dr. Chaudhuri has forwarded the same link there.
Change his name. Let him log out and let him log in with his name.
Yes, Sudhir.
Kallyan,
Yes.
you log out and log in with the other link.
He can rename himself over here also.
He can rename? Okay, do that. In the meantime,
What do I have to do?
Let's get Ray to share his screen. Ray, plus you can press that share screen button at the bottom. Yeah, okay.
yeah. Hi, I'm in the webinar. No, I'm just doing a pre-check. Okay. So let me try. So I'm going to share screen.
Yes.
And that's my presentation.
No, don't start the presentation yet. Before you click on the presentation, wait. So just click on screen, share screen, and then it will pop up saying your desktop or whiteboard at the bottom.
Optimize screen sharing for video clip.
Yes.
Okay, great. Because my videos are embedded in the slides.
Yes. No, once you optimize it, then it doesn't become jerky.
Okay, great. Yeah, thank you.
You still want to see if that works, sir?
Let's do it once.
Yeah, let's just try. And can you see my slides now?
Yes, we can.
Yes.
So I will go to a video slide and see if it works. It's this one. Sorry.
Everything all right with me?
Yeah.
Body's twisted and you're getting pain, is it?
Yes, you work really well, sir.
Yeah,
okay, great. Thank you. That's great.
Only one request, Dr. Chaudhuri, is that while your video is playing, if you talk, your voice will not be heard. So I'd request you to like pause the video in between and then talk, or talk either before or after the video?
Or
Thank
you can mute the video. If you
Or
don't
yes.
want the sound in the video, you can mute the video and keep talking. But if the video sound is also going on and you're also speaking, then it becomes confusing.
Yeah, okay.
Sudhir,
Great.
am I
Thank you.
audible? Am I visible? Am I audible? Everything all right with me?
Yes, you are. And now you have come back as a Kalyan avatar.
Very good. What was his name before? Is that Professor Bhattacharya?
That was
Indeed, I
Professor
am.
Chaudhuri.
No, he was.
How are you, Ray? How are you, Ray? Have you
I'm
changed your
fine, but
specs?
it's a
Have you
great
changed your
pleasure and
specs?
privilege to just hear your voice.
Thank you
Yeah,
so much.
No, it's rare that Kalyan says, "Can you hear me?" Because we can.
I know. He's always heard.
Yes.
Thank you.
But Kalyan, today
Yes.
I can make it Kalyan is seen but not heard. I can mute you from here.
Please do.
Okay, I think we are 1 minute off. Ray, we can start in a minute. And Siddharth, you can begin by introducing him.
Yeah, let me just share my screen and that's. Whenever you say, Mansi.
We can start. It's 8:30.
Okay, so it's my great privilege to introduce my teacher, actually, Dr. Ray Chaudhuri. He is a professor at King's College in London, and he's really a world-renowned expert in Parkinson's disease. His special interests, of course, are non-motor symptoms, and he is the creator of the non-motor symptom scale and the Parkinson's disease sleep scale, the most widely used scales for measuring this. These are used in all research papers. He has more research papers than can be counted. He is an editor of multiple books. He's also been active in making some of the guidelines that we follow for some of these diseases. So he's the chairman of the Restless Leg Syndrome UK and the International Parkinson's Disease Bureau Non-Motor Symptoms Group. He is also an active member of the American Academy of Neurology, and he is the chairman of the Appointments Committee of the Movement Disorder Society. He has been felicitated with many awards. I think most of you might know him already as a professional, but I just wanted to say that it was a great privilege for me to spend some time with him, and he's a truly brilliant teacher and an extremely nice person, and I think we will see some of that today. Thank you. Over to you, Ray.
Thank you, Sid, for those very kind words. So I hope I can do justice to this. I think what I will do now is I've titled this talk as a short journey for the management and treatment of non-motor symptoms. Try to make it practical as far as possible. So I'll start sharing my screen. And is this? Let's go back. I'd just like to talk to you today really about the evidence base of certain aspects of treatment of people with Parkinson's as they come and see you in the clinic. And I've tried to make it very practical so that it's relevant to everybody, not esoteric treatments that can only be provided in selected centers. And before I start, these are my disclosures. I think it's worth remembering that I do have some conflicts with certain products and so on. It's worth remembering that. And this brings me to the current understanding of Parkinson's, that fundamentally, what you see in the clinic is the tip of the iceberg, which is the motor aspect of Parkinson's, the dyskinesias, the tremors, the bradykinesia, the gait difficulties, handwriting, and so on. But probably the vast bulk of the problem of Parkinson's relates to the non-motor aspects, which is the hidden parts, is almost the submerged part. And my talk today really will focus on this hidden aspect of the iceberg. So that takes us to the first concept that I think it's really worth remembering, that if you're trying to cover the entire management aspect of Parkinson's and the non-motor aspect, and this is a review that we published a couple of years back, it covers every part of the body. So it will be impossible to cover all of that in a short period of time. And I'll try and focus on some specific problems, particularly neuropsychiatric issues, a little bit on the fatigue and apathy and depression and anxiety, pain, sleep problems, as far as one can, a little bit on autonomic dysfunction. Are you able to hear me?
Yes, we
Yeah,
can hear
good.
you.
Yes, we can.
Thank you. So first, let's talk a little bit about neuroprotection and neurorestoration. This is very important because if we understand how Parkinson's, the neuronal counts fall, it's in the green line. Neuroprotection aims to stop the progression and keep the trajectory horizontal, like the black line. And neurorestoration comes in later, where it might try and push this particular gradual deterioration to the green line again. So those are the two areas that we are interested in terms of Parkinson's. And where are we with both these aspects? Well, here is a list of the drugs that are being used currently in terms of therapeutic targets for neuroprotection. You see iron chelators there, you see exenatide, or drugs that work on the diabetic system, the GLP-1 agonists. You see gene therapy, you see vaccination, active and passive against alpha-synuclein, and a whole range of other drugs as well. So there's a lot of agents that are being tried, but underpinning this large amount of research lies a fundamental problem. That fundamental problem is highlighted here. So here is a summary of the different types of drugs that have now been used to try and see if they can cause neuroprotection. And these includes, as I just showed you, iron chelators, gene therapy, to enzyme inhibitors, to glutathione replacements, and so on, antioxidants. But all of them have failed. And this is the latest failure. It's radapine, which, as you know, is a cardioactive drug, thought to have effect on the dopamine system, protects neurons in the animal model, but was shown to fail in neuroprotection in the trial presented at the American Academy last year. So the latest one, and I think this is the 37th drug that's been used. And so in some ways, I equate neuroprotection to this factory of skulls. You can find this in the University of Padua, where all the professors, after they've died, their skulls have been collected from the old days. And it's not a good sight. And you can see that many claims that we have for neuroprotection have not really worked. So I think we need to keep a really open mind on why this is so. And in particular, this is because that we tend to focus only on dopamine when we come to neuroprotection, but we know that Parkinson's is not just only a dopamine disorder, noradrenergic, dopaminergic, cholinergic, and serotonergic problems. And so if you just want to treat or neuroprotect just by using dopaminergic drugs, it's not going to work. So I think that's broadly the reason why neuroprotection is not working. Okay, now let's talk about the problem. Let's talk about neuro therapy for non-motor in Parkinson's. This is a study that was published a few years back. What do the patients want? The patients want treatment for their fluctuating response to medication as their number one symptom. But in addition, you have mood, dribbling of saliva, sleep, pain, bowel, urinary, appetite. These are all non-motor, and these are all listed by the patients as the most bothersome symptom to them. So treatment that we offer our people with Parkinson's needs to focus on these non-motor aspects. And one of the best ways that you can probably get an evidence, people who say that non-motor symptoms are a bit of a waste of time, etc., they should look at this paper that we published in 2011, that if you look at the overall burden of non-motor symptoms and quality of life, the closest correlation to quality of life, which is PDQ 39 here, with the non-motor burden is the non-motor burden, not motor symptoms, not dyskinesias, and so on. So it's the non-motor symptoms management that really drives quality of life in people with Parkinson's. So it's very important to recognize this in clinical practice, that you have your patient, you've done the dopamine treatment for their bradykinesia or dyskinesia or whatever, but don't forget the non-motor aspects if you really want to address quality of life. Okay, now this is a review paper that Tony Shapiro and myself published in Lancet Neurology a few years back. And here you can see, you probably won't be able to read it all, but non-motor symptoms span neuropsychiatric, cognitive, sleep, autonomic, gastrointestinal, sensory, and others like fluctuations, like fatigue, like vision, and so on. It's impossible to cover all of this in one talk, but I'll try and cover perhaps some more relevant ones which will be of interest to you. The other thing to remember, and that we highlight in this particular paper, is that some non-motor symptoms of Parkinson's respond to dopamine. So there is a view that non-motor symptoms means non-dopaminergic. That's not true. Parkinson's symptoms can respond to both, non-motor aspects can respond to both dopamine and non-dopaminergic treatments. And therefore, it's important to remember which non-motor aspects of Parkinson's have a dopaminergic basis or can respond to dopaminergic treatment. And the other thing to remember is one size doesn't fit all. Every Parkinson patient has a different phenotype in some way, so you need to personalize treatment as much as possible. And that means drugs, that means doses, that means strategies. So there are various different ways you need to look at this particular problem. So let's look at firstly the depression and anxiety issue in Parkinson's. Depression is very common in Parkinson's. Various studies have suggested major depressive disorder in up to 17%. Anxiety, you can see anxiety disorder in 25% of our people with Parkinson's. Other studies would suggest that up to 43% might have a depressive disorder, 67% with comorbid anxiety, and those who are depressed are also highly likely to be anxious. And the two are quite different, and it's really worth remembering that to make the difference between anxiety and depression. And if you look at the prodromal features, this nice review of different factors that have an influence on the future development of Parkinson's by Alistair Noyce and colleagues from Annette Schrag's group, showing that mood disorder here, along with constipation, appears to be one of the prominent features that gives you an increased risk of PD, Parkinson's disease. So people who have high rates of major depressive disorder by itself might be more prone to go on to develop Parkinson's in the future. Therefore, this is a really important aspect to consider. I just mentioned to you that in that review article that many non-motor aspects of Parkinson's could be dopamine driven. And it's worth remembering that depression is particularly one which has a strong dopaminergic link. This nice series of studies from David Brooks's group and Philippe Remy from France, suggesting that if you did a PET study using this marker of dopamine and noradrenergic transporter binding, you found in depressed Parkinson's this dopamine binding is very very reduced compared to those who are not depressed. So what this study is telling us, that if you have a Parkinson patient who's depressed, there is probably a problem in the dopaminergic pathway and the noradrenergic pathway. So your best treatments might be drugs that target these two pathways, although traditionally we often treat with serotonin reuptake inhibitors. And there is a little bit of a paradox there. And there is also growing recognition that depression and anxiety can be of specific subtypes within Parkinson's. So you're going to see, and in this review paper, if you can look at this particular bit, some of your patients will be just purely depressed. Others will be having this combination of anxious, depressed. Others will be very anxious, and there are differences. And you need to recognize this because the treatment is different. Anxious, depressed ones are usually with fluctuations. So here you need dopaminergic long-acting treatment. Those who are purely anxious need anxiolytic treatment, where serotonergic drugs are more effective. However, those who are clearly purely depressed, you would want to use noradrenergic and possibly dopaminergic agents. And it's also worth remembering that there is quite a good literature that has shown that serotonin reuptake inhibitors are not that effective in Parkinson's. This unresponsiveness in the first study was 46% after 6 months. And also, there is resistance because of age, fatigue, as well as executive dysfunction, all of which might coexist with depression and make your SSRIs less effective. Dopaminergic drugs have been useful. So here's a paper from reticotine patch. You can see here depression was assessed by HAM-D, which is a HAM-D 17 scale. And you can see in the versus placebo, reticotine had a very strong effect. And as you know, reticotine is a dopamine agonist. Very similar data is there from before, even stronger data with pramipexole. So we do have evidence that dopamine agonists can help the dopaminergic aspect of depression. And if you look at this review paper, which has just been published last year from the Movement Disorder Society, and I'm part of this particular evidence-based review, the evidence is that at this moment in time, these are all the lists of different drugs that have been tried for depression in Parkinson's: dopamine agonists, monoamine B inhibitors, tricyclics, SSRIs, other antidepressants, alternative therapies, and non-pharmacological interventions. The ones that are highlighted, reticotine, rasagiline, have been shown and are still being investigated, but you can see the efficacious ones are only pramipexole and here venlafaxine. And if you remember, venlafaxine has also a noradrenergic action. So in terms of current evidence, if you only go by level 1 evidence, your options to treat depression and Parkinson would be either a dopaminergic drug such as pramipexole, or even reticotine, or venlafaxine. But of course, in clinical practice, we use many other drugs, and nortriptyline, citalopram, which is mainly an SSRI, as well as paroxetine have been used. It's worth remembering that there is a growing evidence that transcranial magnetic stimulation, given in a repetitive manner, can also be a reasonably good treatment for depression. And certainly in the US, and also here in London, we have several clinicians and practitioners who have opened up TMS clinics now to treat depression, which includes depression of Parkinson's. Okay. There is another interesting aspect to neuropsychiatric problems, particularly depression and anxiety. This is a very nice paper, old paper, but very nice. You see here, patients are being given intravenous levodopa. And what's happening, you're measuring mood, you're measuring anxiety, and you're measuring motor score, and you're measuring the plasma level of levodopa. As the infusion is done, the patient is on, right? That would mean the plasma levodopa level rises, their tapping score goes up, they got more motor function, their anxiety drops, their mood improves. As soon as the drug level drops. In other words, the patient hits an off period. Here we see the drug level drops, the tapping speed drops, their anxiety goes up, the mood goes down. So there is a clear relationship with dopamine fluctuation with mood and anxiety. So if you have a patient who's very severely depressed and anxious, always think about fluctuations. And in these patients, you might be preferentially better off using drugs with a longer action. So you can use transdermal patch, you can use longer acting agonists perhaps, or you can use apomorphine infusion, not injection, but infusion. So depression and anxiety specifically have a very close link with these problems. And I'd like to now show you this video.
Down my side, my body's all twisted. The body's twisted and you're getting pain, is it? Yes, I have pain down my back, all down here. Okay, why don't you take the rest of the medication now? Do you feel quite tense and anxious? Yes, I'm stiff. I can't, I'm just not kicked in at all. Okay, okay. That's it, very well done. You'll see it slowly will settle down now. This is Mr. Owen Lampard. Mr. Lampard, can you would say you're in off period at the moment,
yes,
are you?
Yes, I am. Yeah.
And can you just describe the symptoms with the off period?
I have a feeling of tightness around my head.
Yes.
So just to quickly show you those two videos, I don't know whether the voice was clear, but the lady one had severe anxiety with the off period, which I could overcome by giving her some liquid levodopa. She was not bothered about her pain or tremor, and she was bothered about her pain, but not about her tremor or bradykinesia. And the other gentleman who talks about his mind being cloudy and him having severe paresthesia as part of the off. So depression, anxiety particularly can be phenomenon associated with fluctuations, motor fluctuations in Parkinson's. And how do you manage anxiety? Well, here are some examples of my fellows undergoing a lot of anxiety. And that's largely secondary to me. But if you look at the specific treatment, anxiety treatment is slightly different. Here, selective serotonin reuptake inhibitors are actually quite a preferred option, unlike major depression. You can also use serotonin norepinephrine inhibitors. In this respect, I tend to use venlafaxine in this particular group. But you can also use benzodiazepines. Some people have tried buspirone and cognitive behavioral therapy. So you do need to make the distinction between what is anxiety, what is depression, and whether there is an overlap between the two, and then choose your treatment and rule out the possibility of motor fluctuations in particular. Okay, staying on with neuropsychiatric problem, what about psychosis? In this particular time when we have COVID-19 all over, some of our Parkinsonian patients are likely to get infected, they're likely to get admitted. And if they're admitted, they're likely to be, particularly if their viral load is high, they might be in delirium or they might have psychosis. It's worth remembering the difference between the true delirium is usually acute, it's usually fluctuating, unlike psychosis, which often progresses. The conscious level is often impaired in delirium, and they have very poor short-term memory and attention span, and they often have other concurrent problems going on. So these things are important to remember. And if you then think that somebody has psychosis, this is also quite important to recognize what type of psychosis you're dealing with. So in other words, here you're looking at hallucinations. These are minor when you have just a passage hallucination, illusions, or sometimes even diplopia. You can have hallucination with insight, but when the dementia starts happening, patients get hallucinations without insight, and then you can get delusions. And these really also correlate with the motor stage of the condition. And it's what are the different medications we can use. Well, this is the recommendation. In terms of evidence base, the most efficacious is clozapine, but certainly in the UK, we have difficulty using this because it's only prescribed by psychiatrists here, and you have to monitor bloods every week, but it is a great drug. We do not use olanzapine or risperidone because it really blocks your dopamine receptors badly, the D2. So it really renders people often very, very akinetic. Quetiapine, although it has insufficient evidence, we do use it. And it also has another very good effect in that it also causes a degree of sedation. Many of the psychosis patients in PD also have sleep very badly. Quetiapine also hits the sleep quite well, but you might need to go up to reasonably high doses. And you have to, of course, check the cardiac status for any QT interval abnormalities. And finally, there is growing evidence on pimavanserin, which has been more recently released. Pimavanserin is an antipsychotic, which is a serotonin 5-HT2A inverse agonist. So in other words, it propagates the serotonin work, serotonin function. It therefore has a good effect on more anxiety and anxious, depressed phenotype, but also people with hallucination. And however, there is a concern that certainly FDA was worried about increasing deaths. And there's a very nice editorial on this topic in Lancet Neurology that was published last year. So you have to use your individual sense of take on it. It's certainly not available for us here in the UK at the moment because the European Union is still looking at the data before they are passed, but it's available certainly in the US. I'm not sure where we are in India with pimavanserin. Okay, dementia. Dementia, I've put this paper up, The Inevitability of Dementia at 20 Years. So according to this paper from Maurice Hilly and others in Sydney, from John Morris's group, you would think that any of your Parkinson patients who survive 15 to 20 years will go on to develop dementia. That's not true. This is a very recent paper from Simon Lewis collaborating with us. And we have shown that you might even have patients who have more than 20 years of Parkinson's, but who are not demented. And so again, my basic message, one size doesn't fit all. In Parkinson's, more than anything else, you need to have a very open mind. And therefore, when people ask you, doctor, am I going to have dementia in 15 years? The answer is, I don't really know. There are some risk factors that might predict that. If you have that, well, and fair enough. But if you don't, dementia may not be an inevitable consequence in Parkinson's. Of that, let's look at what other ways we can manage the issue with dementia. I'll come back to the subtypes later. The cognitive decline in Parkinson can be a really particular problem in our patients. And often the best way to judge this is to see, when you see your patients, just to make sure whether they do have any mild cognitive impairment or not. And this is particularly relevant if the patient is at the de novo stage or first time presented or you've made a diagnosis. Cognitive and psychiatric problems are very common. And of course, the fundamental thing that drives cognitive issue in Parkinson is aging. We all age. I put out the figures of a band that was very well known in the 60s in London called King Crimson. And here you see them performing in 2017. So of course they've all aged, but it doesn't mean that they're all demented. So age has a particularly interesting contribution to the cognitive decline, but aging appears to be a particularly potent factor towards dementia if you have mild cognitive impairment at baseline. And how do you determine mild cognitive? You don't need fancy tests. You don't need this fancy genetic testing that I see a lot of these presentations in various meetings. You don't need fancy PET scans, etc. You just need to do 2 tests. You ask the person whether they can name some animals, and you see how many animals they can name in a minute, ideally in 90 seconds. The normal range is about 20 animals in 90 seconds. The other one, you ask them to draw a pentagon. Now, if the patient can't do any of these 2 or have problems doing this at the onset of their disorder, it's highly likely that they have a parieto-temporal deficit and parieto-occipital deficit. And if you follow these patients up, and this is from campaign study, you can see within 7 to 8 years, 46% of this group will go on to develop dementia. So that's not everybody, but a specific subgroup within Parkinson's. So this is how you can recognize the high-risk patients at baseline. What can you do for these patients? Well, this is the evidence. If you are in very fancy centers, you can do cholinergic PET scans, you can do dopaminergic PET scans, you can do amyloid PET, you can do tau PET, all sorts of things. However, if you can just do those 2 clinical tests and you find that patient is at high risk of dementia and their MoCA or MMSE is perhaps impaired, what do we have? Well, perhaps the best drug we have for evidence-based is rivastigmine. We have this in tablet, we have this in a patch. Other drugs for which there is evidence, and we would rate them as possibly useful, are donepezil or Aricept and galantamine. If you have non-dementia cognitive impairment, so this is mild cognitive impairment, what drugs can be used? Rivastigmine, but interestingly, there is also evidence that rasagiline might be effective, and also in this particular group, transcranial direct current stimulation, TDDCS, as well as cognitive rehabilitation might also be considered. So there are other aspects that you can bring in to this particular group. What is the other importance of knowing this subgroup? You should never use anticholinergic drugs in this group. So use of anticholinergics for treatment of tremor, for treatment of bladder dysfunction, for treatment of dribbling of saliva, not a good idea, because these patients are highly likely to have underlying very strong cholinergic dysfunction at the baseline anyway. So that's another take-home message about this particular group. Rivastigmine has another advantage. Now let's see if this video works.
The following clip shows the profile of a lady who is attempting to walk up and down a corridor.
Okay, so that lady has a classic unrelated freezing, right? The upper body is okay, hands are okay, face is okay, but she's freezing every time she turns. Some people call this a gait akinesia freezing subtype of PSP, but this is actually very commonly seen with the cholinergic subtype of Parkinson's, where dementia or mild cognitive impairment is quite common. And rivastigmine, at least in this study, which was published in Lancet Neurology, called the RESPONSE study, had a clearly superior effect to placebo. So you might also find that using rivastigmine in this group, you're causing a cognitive enhancement, but you might be also helping the gait problem, particularly the unrelated freezing of gait, which is also a cholinergic phenomenon. So it's worth remembering that there could be potentially a double hit from the use of rivastigmine in this group. Okay. Now we go to some couple of other non-motor aspects. What about apathy? If you look at the different phenotypes of Parkinson's, you can divide it into those coming through the brainstem, those coming through the limbic system, and those coming through the cognitive, the more neocortical. Apathy often segregates with the neocortical subtype, so it segregates with dementia, it segregates with mild cognitive impairment, it segregates with depression. How do you rate apathy? By 3 questions. Have you had a reduced motivation to day-to-day activities, reduced interest in talking to people, and a reduction in experiencing emotions? Apathy can be dopaminergic versus non-dopaminergic. Apathy is often comorbid with depression, and apathy is often comorbid with somnolence. And these are important things to remember. Another interesting aspect of apathy is alexithymia. Alexithymia is something that you have difficulty expressing your emotion or your feelings. And this is, again, often comorbid with depressive symptoms. Apathy, from the point of view of origin, can be divided into 3 groups. One is more emotional apathy. Another is cognitive apathy, which you see with dementia, with dopamine fluctuation. So the bottom line of this is you're finding 2 types of apathy. One is driven by cholinergic mechanism. Another one is driven by dopaminergic mechanisms. And it is also known that if you look at depression, anxiety, as in this study from France, and apathy, they are often comorbid. So in fact, in terms of dopaminergic treatment, if you're treating a depressive patient with dopaminergic treatment, you might be also helping their apathy. It's quite a complex interaction, but it's just worth noting this. How can we treat apathy? The recommendation from the MDS is that you have 2 options, basically. The dopaminergic apathy, it responds very well to dopamine agonists. So here, the recommendations are pyribodyl, which is not available for us in the UK, but there is good data on it, and retigatin patch. Both help apathy, and I certainly use a lot of apathy in a lot of patients with retigatin. If you want to use more the cholinergic, if it's more a cognitive dominant apathy, then you should use rivastigmine, but you can also try donepezil. You can also try memantine. In relation to this, we mustn't forget that pramipexole is also very good in terms of managing apathy. This particular head-to-head study in non-demented PD showing pramipexole treated patients had the lowest rates of apathy in this large cohort that Jaime Kulisevsky and others looked at in Spain. So pramipexole, another effective drug for treating depression and for treating apathy in Parkinson's. And then we come to fatigue. Fatigue is something you must all be feeling, listening to me at 9 o'clock at night, but it is a primary construct of tiredness. And it's usually persistent, aversive, and often made worse by stress. Patients can express this in various different ways: utterly exhausted, an awful feeling, leaden heavy, like walking through treacle. Treacle is like very sticky sugar, like a clock that's wound down, feeling really ill. It's mostly things I hear from most of my guys on a daily basis after they've done some work. So fatigue is a particularly important point to remember. If you look at the definition, it's either defined as a sense of exhaustion for a defined period that you cannot explain by drugs or psychiatric disorders, or significantly diminished energy. It's an internal feeling of extreme exhaustion. You can, of course, measure it. And the other thing about fatigue is non-restorative. So if you have a sleep, if you have a little sleep, if you've got excessive daytime sleepiness, that'll improve. Fatigue will not improve. It's a really troublesome problem. We now know that even in de novo Parkinson's patient, if you did a network analysis using connectivity imaging, you see that it is associated with underactivity of the supplementary motor area of the brain and increased activity in the prefrontal and the cingulate area. So there's a mixture of imbalance. And there is evidence from imaging studies, this is work with Dr. Mehta, who might be on the call, that showing that Parkinson patients with severe fatigue, who have fatigue indistinguishable from chronic fatigue syndrome, have a real low uptake of serotonin in the striatum of the brain. This is the normal subject without fatigue, PD without fatigue. Here's a Parkinson with fatigue. You can see very lowered serotonin binding in the limbic striatum. So how can we treat fatigue? And what are the indicators of fatigue? This is again another work from Vinod, showing that if you have a patient with severe fatigue, they're very likely to have also a degree of anxiety and depression, but they will have sleep dysfunction. And interestingly, they are non-fluctuating PDs usually. And also they might have some abnormality if you did their frontal assessment battery, not parieto-temporal, like we showed in the cognitive group, where they can't copy pentagon or can't name animals. This is frontal assessment. So that's the interesting difference from the cognitive group. How can you treat? Well, this is a large, nice meta-analysis. On the left, you see favors intervention, and the other side, you see favors control. You see rasagiline, methylphenidate, which is Ritalin, modafinil, all have some beneficial effect. Levodopa, mild beneficial effect, but again, here doxepin, which is a benzodiazepine derivative, and exercise have all got positive effects in relation to fatigue. So if we bring that down to other aspects, this particular study from Norway also showed that dopamine agonists can also help fatigue. So this is an interesting point. A lot of people have now developed agonist phobia because of impulse control disorder, but we forget that some agonists, as I've already shown you, have some very good non-motor effects, particularly for depression. I showed you for apathy, and now for fatigue. And this shows that better effect of dopamine agonists than levodopa on severity of fatigue. If we drill down more, here is evidence from it. This is the RECOVER study where retigotine patch was compared to placebo. And here you see, if you look at the fatigue scores, retigotine shows a substantial improvement in fatigue compared to placebo. So there is your level 1 double-blind placebo-controlled evidence, but also there is evidence from other drugs, apomorphine, which works to the serotonin, which speaks to the serotonergic receptors, as you can see here. It's not just a dopamine agonist, can be quite effective for fatigue in Parkinson's, as can rasagiline. So there is reasonable evidence base of dopaminergic drugs on fatigue. So what can you use? Well, in my own scheme, I often use amantadine first, because as you know, amantadine has been successfully used for fatigue in multiple sclerosis. You might go up to 400 milligrams. Otherwise, you go through the meta-analysis, modafinil, rasagiline, agonists, and in some cases, if the patients are totally intolerant to all of that, high-dose levodopa can also be tried. And if you look at the MDS recommendation, here, as you can see, rasagiline is only the one that's considered efficacious. You might have to use 1 to 2 milligrams. Ritalin, modafinil are all positive. Insufficient evidence, though. Another agent that has been more effective for fatigue is acupuncture. This is a randomized control trial of acupuncture for fatigue. This actually did not show any benefit in compared to sham acupuncture, but if patients had self-reported fatigue, they showed better for acupuncture, slightly better. So this was not significantly improved. So this was in effect a negative study. However, another study from Ike Tan and Louis Tan from Singapore showed a different data. In this randomized controlled study, acupuncture did cause improved fatigue compared to the sham acupuncture group. So the evidence is mixed. And there is also evidence that resistance training program, this is essentially exercise programs, graded programmed exercise has a very good effect on fatigue and on particularly on balance, dynamic balance. So all of these things will need to be considered if you have a patient with Parkinson's with severe fatigue. And to summarize, therefore, rasagiline, methylphenidate, as well as dopamine agonists, along with possibly acupuncture and exercise therapies, might be the ways that you might want to look at management of fatigue. I have very little time left now, so I'll quickly go through the rest. I'll touch upon pain very briefly. Pain is a really troublesome problem. In Parkinson's, there have been lots of different review articles and articles, many of them from our group. We described the first Parkinson pain scale, which is now widely used, and subsequently a pain questionnaire. If you don't have time to do a scale, you can ask your patients to complete the questionnaire, which will then give you a quick snapshot of the different type of pain the patient might be experiencing. One specific type of pain that you need to be aware of is unexplained lower limb pain syndrome. Now, I'll see if this video works.
This is Mr. Chris Garrett. Mr. Garrett, just describe the pain that you've been just telling me about a little bit.
Okay, Professor, it's pretty consistent in the left leg, which is the leg that shakes.
Right.
And most of the time it simply hurts, a dull pain, which is exacerbated by long hours of inactivity such as sleep. So that when I actually get up in the morning, not that I actually sleep very well, but when I actually get up in the morning, it's a struggle to motivate myself.
And so the pain doesn't really fluctuate that much, it's sort of there most of the time.
No, it certainly doesn't fluctuate. It's an ache rather than acute pain.
Right.
For the sake of time, I'll go back. So this is what we call ULLP, unexplained lower limb pain syndrome, usually seen in middle-aged males. It's usually seen in non-fluctuating PD. It's often in the anterior aspect of the lower limbs and the pelvic area. Physiotherapy does not really help, and dopaminergic drugs often don't work. This type of pain responds really to opiates. And this is a central pain syndrome. And often these patients are subject to a lot of orthopedic interventions. They have a lot of MRI scans done. Some even have operations done, which does nothing to their pain. So it's really worth remembering this particular variant of pain in Parkinson and the fact that this is largely central pain syndrome, where opiates are probably the best drugs to use in spite of their side effects. And if we look at therefore the recommendations from the Movement Disorder Society, you have one group of pain where the pain is occurring due to fluctuations. In that particular group, drugs such as retigatin, but also I would add apomorphine and levodopa infusion, as well as DBS, can be extremely effective. In fact, deep brain stimulation now has a very strong literature on contralateral limb pain, which gets better with DBS. However, if you have this central pain syndrome, you need to think about non-dopaminergic opiate therapies here, oxycodone or Targinact, or in fact tramadol, or that group of drugs might be the best drug, and there's some clinical trials. Certainly there are 2 randomized placebo-controlled trials, one with retigatin, one with Targinact, that has shown some benefit, but a lot of work needs to be done here too. Other aspects of pain, therefore, how will we summarize? But the only one we can recommend on the evidence base is retigatin in terms of dopaminergic drugs. Non-steroidal anti-inflammatory drugs can help in musculoskeletal pain. Baclofen, benzodiazepines you might have to use, but if the patient has neuropathic type pain, then gabapentin probably is the best drug. Musculoskeletal pain can be a real problem, so you have to rule out arthritic issues, particularly you might need physiotherapy, and postural changes, camptocomia and Pisa syndrome, often associated with pain, and in these patients you might have to use baclofen. Botulinum toxin injection to the overactive muscle groups, very difficult, but can be done. And some people have suggested DBS might be very useful in catatonia. In our own experience, we've found levodopa infusion therapy to be quite effective as well. So these are all open label observational effects. There are no formal or very strong evidence base to support it, but it's worth considering. And acupuncture. This is a recent paper that we collaborated with the Taiwan group showing that in patients with central pain syndrome, selective acupuncture can lead to up to a 46% reduction in the King's Parkinson pain score, and it activates some specific circuits within the brain. So proof that this type of pain, like I showed you the ULLP subtype, is actually a central form of Parkinsonian pain syndrome. Other things, I don't really have time to go through sleep and dysautonomia, but here's a quick summary of sleep and wakefulness management. Insomnia, very common in Parkinson's. You have to think about what type of insomnia it is. If it is difficulty falling asleep, which is sleep onset insomnia, you might have to go with hypnotics like zopiclone or esomeprazole or melatonin. But if it's sleep maintenance insomnia, you need to use drugs, dopaminergic drugs that work all through the night. So here you have dopamine agonists like retigotine or apomorphine through the night, or control release levodopa given a few times. If you have excessive daytime sleepiness and sudden onset of sleep, probably modafinil up to 200 to 400 milligram in some cases. High caffeine, some people say it works. In my view, I haven't really seen it work, and it can cause a lot of tachycardia. If a patient has significant problems with sleep apnea, of course, CPAP would be the way forward. Retigotine probably has the most effect research in relation to sleep. And if you look at this review article that we wrote a couple of years back, there's a full summary of the different effect of retigotine on sleep on different trials. Interestingly, retigotine patch at night can also help with nocturia, which is a real problem in Parkinson's, people getting up at night to pass urine. So it can actually, both retigotine patch at night as well as apomorphine can be really good treatments for nocturia, and it's worthy keeping that in mind. Sudden onset of sleep or sleep attacks can be a real problem. These are pictures of some of my patients falling asleep while they're either eating or talking, and one patient has fallen asleep and cut open his head, so needed stitches. Narcolepsy can occur in your Parkinsonian patients, about 10%. These patients should not be driving because they will fall asleep if they drive, particularly if they're taking pramipexole and ropinirole. So you have a real problem here. I previously said pramipexole is good for depression, is good for apathy, is good for aspects of fatigue. But if they have sleepiness, it's a bad drug to use because it can precipitate a narcoleptic event. And that's something worthy of remembering. In the UK, we have released a document with the DVLA, our driving agency, called Dead Tired, where the doctors are warned not to prescribe pramipexole in particular or ropinirole for people who have this narcoleptic phenotype. And it's worthy remembering this in clinical practice. The other therapy that you might want to be aware of is for rapid RBD. Many of your patients, up to 30%, might have RBD. You might, there's at least one case in report where a man killed his wife during RBD. He shot his wife, imagining she was an intruder. So it can have rather disastrous effects as well. I think that if you want to manage RBD, particularly if it's a very physical RBD, the patient often says they're falling out of bed or hitting their partners, removing sharp items from immediate sleeping area, padding bed rails, putting mattress or pillow on the floor is very useful. And then your medications. The two main medications are mainly clonazepam and melatonin, but you must rule out drugs which exacerbate RBD. Sometimes SSRIs, and sometimes tricyclics, and sometimes even selagiline in particular can make RBD really worse. And you must rule out sleep apnea, because sleep apnea can make RBD a lot worse too. In terms of management, we already know about clonazepam. There's a lot of literature on melatonin, and it's worthy of remembering that melatonin to be effective in RBD, you need to use at an average dose of at least 6 milligrams. And there is at least one trial published last year showing at 4 milligrams, it has no effect over placebo. So for melatonin to be effective, 6 to 12 milligrams, some of my sleep guys, colleagues would use even higher dose of melatonin. And there is a literature. Here you can see somebody with RBD in the sleep lab, this patient. Now here's the leg movements. He's kicking, now he's shouting, and you can see he will fight off an intruder. And in this group of patients, sometimes there is some literature, open label, that pramipexole might be useful. I've personally had very little experience of it. It'd be interesting to hear whether or not if you had any experience of pramipexole treatment for RBD. Autonomic dysfunction is the last one. Orthostatic hypotension I will not deal with because it needs a separate talk. But in terms of constipation, the most important thing to remember is to rehydrate the patient. The commonest cause of constipation, Parkinson, is dehydration. Then macrogol has got a double-blind placebo-controlled trial. There is also lubiprostone, praculoparide, use of probiotics and abdominal massage. All of these might be helpful. If you have a patient with severe dribbling of saliva, ipratropium bromide or atropine spray can be tried. I would not recommend atropine drops in anybody with cognitive issues, but otherwise, atropine drops can also be used. Glycopyrrolate is recommended here in the UK, but for us, the most effective treatment is botulinum toxin A. Dr. Mehta does it very well. Injecting straight into the parotid glands and the submandibular glands is really effective. If you have some experience of it in our hand, that's probably the best treatment. For urinary dysfunction, again, there's a lack of good quality trial. There is at least one trial, double-blind trial of solifenacin, but again, you have to remember the anticholinergic aspect of it. So again, may not be a particularly good treatment to use in people who have cognitive impairment. Impulse control disorder. This is a vignette, pictures from several guys in our group, including the famous Professor Jenner here. Impulse control disorder are a real problem for our patients, isn't it? I mean, particularly with the use of dopamine agonists. But this is what, if you look at specific management, of course, the management would involve withdrawing the agonist, reducing the agonist, ensuring that your patient doesn't get agonist withdrawal syndrome, keeping the drug as clean as possible, but also use of drugs such as amantadine. There is at least one study, and it can be tried. And there's one randomized placebo-controlled study of naltrexone, which is an anti-opiate, which has shown some benefit, but very weak. And again, as these patients have significant mood disorder, cognitive behavioral therapy might be another aspect. But as of date, we do not really have a very strong evidence base for management or impulse control disorder in Parkinson's disease. It's also worthy of remembering, there's a very recent paper that we published that ICD is also, or can be also evident in people with Parkinson's who have dementia. So it's not just people non-demented PD, but also in dementic PD. And you have to keep an eye on it because impulse control disorder in dementia PD poses a separate challenge. And these patients can therefore have dopaminergic drug abuse. And therefore, this is something that you need to also keep in mind. The management of it is incredibly complex and difficult. What are the newcomers? Well, we have all these new drugs coming up. This is the new AbbVie product, which is a skin site, and then the infusion, which is subcutaneous, goes through it. This is levodopa infusion. We also have a vestibular stimulation trial coming up, which by wearing a vestibular by headphones and giving caloric hot on one side, cold on the other side, stimulates your vestibular nucleus. And that has shown some dramatic effect on non-motor symptoms. And so there's a large double-blind trial now planned to see if this headphone use with caloric stimulation might have a global effect on non-motor symptoms, as has been shown by one trial where one of our fellows, Alexandra Podlewska, took part. But as you can see, the data is like uniformly positive. Whether or not this is really true, we will examine in a large-scale, double-blind, placebo-controlled trial. And finally, exercise. There is a really growing body of randomized controlled trials, which are all listed here, that various grades of exercise have, as I showed you already, have a good effect on fatigue, but not just fatigue, on depression and anxiety, on balance, on gait, and possibly also on sleep and social functioning. And certainly in the UK, ballet has taken off. I can't see it being a tremendous success in an Indian setup, but you might have to look at other forms of dancing. But dancing is thought to be really particularly good because it involves learning along with physical exercise. So this might be another way forward in terms of overall management of the non-motor aspects of Parkinson. So I think to end, at this moment in time, I have to say that if you really look at strong evidence base for managing the non-motor symptoms of Parkinson's, it's really quite a bleak landscape, like this Namibian desert that I've taken a picture of. You know, we don't really have very good evidence base because we don't spend money. We spend money yet again on treatment of either genetics, which affects only 1% of Parkinson's, or we go on about the motor function, whereas as you can see, a whole range of non-motor symptom blights the landscape of management of Parkinson's. So evidence base is really emerging, and if people want to do research, I would strongly advocate that you take on a trial, a good trial, addressing some of the non-motor aspects of Parkinson's. They're not a single trial, good trial on anxiety, good trials on fatigue, good trials on apathy, good trials on aspects of autonomic dysfunction, all are lacking. The industry and researchers really need to start this high quality trial. And of course, only when we manage non-motor symptoms well, I think that's when we might get a handle on neuroprotection as well. But that seems at this moment in time a long way away. I'd like to thank all the guys working with us and all our colleagues, particularly our overseas colleagues as well. This is the PRI group, which we are very proud to be part of, with many of our Indian key opinion leaders listed there and shown there, and Dr. Mehta, who's sort of tried to liaise and coordinate everything. I think I had those pictures. So anyway, I think I'd like to stop there. So I sort of went through a whirlwind journey of non-motor management in Parkinson's, and I'm happy to take some questions. Thank you very much.
Thank you very much for the talk. So there are quite a few questions. I'll just go over some of the interesting and more general ones. So Dr. Sunil Gajare sir asked, would you use pramipexole for an elderly person? For example, somebody who is more than 65 years of age. Wouldn't that precipitate psychosis?
Not necessarily. If you use it carefully and monitor it and usually keep the dose low, there's absolutely no reason to think that that patient will become psychotic. In fact, we have data of good tolerance of these drugs in over 80 years of age. Of course, you won't use it in somebody who's already got a cognitive issue.
Sure. The next question is from Dr. Santosh Ennis. The same thing. Overall, what medication do you think is the best for severe anxiety?
Well, that's a very good question. At this moment in time, we don't have a really good evidence base for treatment. I think when it comes to anxiety, it's worth remembering Parkinson patients have a GAD, generalized anxiety disorder, many of them. So what we need to find out, is this anxiety fluctuating or constant? If it is fluctuating, it's very likely to be the anxious depressed subtype, which goes with motor fluctuations. In that situation, management of the motor fluctuation is absolutely key. and you want to use whatever you want. You can use a enzyme inhibitor, you can use a reticulatin patch type drug, any drug that will give you a continuous drug delivery strategy.
Sure.
If you have fairly constant anxiety, then you have to probably go with a SSRI group of drug, and drugs such as or SNRI, venlafaxine and citalopram are both reasonably effective. Yeah.
Sure. In terms of psychos, sorry, go ahead.
There are a lot of articles on rotigotine. Is there any advantage to that over Pramipex or ropinirole, or it's just that because of the delivery, it's easier to give it?
Do you mean in terms of depression, anxiety, or generally?
Yes, particularly.
Yeah, I personally prefer to use rotigotine because of the fact that even if you look at the rates of the impulse control disorder, rotigotine has the lowest rate, so you are safer. However, the evidence base for depression management is stronger with pramipexole. So it's a balance. But my personal experience, I use rotigotine because, as I also showed, that rotigotine has the best evidence in terms of sleep. So you're also helping that aspect of Parkinson's as well.
There's an interesting question, Ray, by somebody. Is ULLP a part of RLS, the low limb pain?
Yeah. No, it's not. No, it's a very it's quite a proximal pain. It rarely goes below the knee, and it's fairly constant. With RLS pain or the asthenia crurum dolorosa, that's the sort of painful RLS phenotype. They're usually unilateral, and they often happen at night, and they satisfy the RLS-SG criteria. This one doesn't, but of course it can overlap.
And you didn't talk about apomorphine and depression, help, anxiety.
Yeah, I mean, I put that in as a generic. You see, there are no specific evidence that apomorphine has been tried for depression, but just like rotigotine, just like pramipexole, it's a potent agonist, and it does improve mood quite considerably. I didn't have time to go over all of that, but advanced therapies, in particular apomorphine and levodopa infusion, both have a very strong effect on depression. Yes.
Okay.
Positive effect.
And the last question was, how do you treat hypersexuality?
Hypo, is it?
Hypersexuality.
Oh, hypersexuality. Well, I mean, hypersexuality falls into the rubric of impulse control disorder with compulsive gambling, hypersexuality, and so on. So first thing is really to find out the cause. More often, I mean, very rarely it has any other cause apart from the use of dopaminergic drug. In this situation, agonists are often to blame. And the drug that causes hypersexuality the most is ropinirole, particularly high-dose ropinirole, over 16 milligrams. So in my clinical practice, I don't have a single patient now who's on ropinirole more than 14 or 16 milligrams. So that's number one. Second thing is to reduce the agonist dosing right down. And if required, very rarely, you might have to use a concomitant antidepressant therapy as well. And in some patients, we have referred them to psychiatrists. So there are those strategies, but I think the main thing to rule out is the agonists, particularly the dopamine D3 agonists, who have a specific aggravation of this hypersexuality angle.
And we do see it with the DBS as well. So in that case, what do you do with the deep brain stimulation?
Yeah, you see, the literature with DBS and ICD is very confusing because on one angle, there is a body of literature which suggests that DBS is good in ICD, if you have impulse control disorder, you can do deep brain stimulation, you can take them off the agonist, and you do quite well. Then there's studies from South Korea and others have shown that ICD might emerge after DBS. And that might be the use. That's when probably some of the stimulation parameters are not working very well and the patient needs additional supplementation with dopaminergic therapy. So the literature is very complex. And again, I don't think there's any specific advice in this situation apart from trying to rule out what might be causing the hypersexuality. I think it's highly unlikely you'll find a patient who has just DBS, maybe STN, DBS, but no other treatment who gets hypersexuality. Usually there will be some medical interventions going on which you then need to track down, usually an agonist.
You talked about the MAO-B inhibitors. What about safenamide? Does it have a little better role than rasagiline or the other
Yeah,
MAO-B
it's an excellent question because there is a lot of interest in safenamide, particularly from the, because there's some of the pivotal studies were done from India by Rupam and colleagues. It has an interesting role, as he said, with monoamine oxidase, of course, but also with the glutamate pathway and also with the sodium and potassium channels. So there is evidence to suggest it might have an effect on pain, and there are trials now going on, at least a couple of data, indirect circumstantial evidence have been published. There is also some evidence to suggest it might be actually beneficial for fatigue, but we have to wait for the data. It's a very good drug to consider as a bridging when you have various different non-motor aspects and you're not really satisfied with what's going on. But of course, if you are going to use safenamide, you will have to take the person off the rasagiline. So there is, you have to
That's right.
balance that out.
Yeah. Correct. Yeah. And any more questions, Siddharth?
Yeah, Dr. Mukesh really had a good question. Can the data that we have on Parkinson's disease be used to treat non-motor symptoms in Parkinson's plus syndromes? Or do we
I was just going to ask him the question.
It's a very interesting question. I mean, to be honest, I really don't know, but to me, it sort of makes sense, particularly if you look at the alpha-synuclein. We know that there is a huge overlap between what some people would call early dementia in Parkinson's and DLB. So clearly there is overlap there, and the same drugs can be used, particularly the antipsychotics and the rivastigmine group of drug. So in some aspects, yes, but I think it needs some studies of an open label.
Okay, great.
Great. Can I squeeze just one set of questions, because there's a lot of questions about this, about freezing of gait. So should we consider rivastigmine for all patients with freezing of gait? What is
no, I would not recommend that. I mean, I just showed that one study that Emily Henderson from here in the UK, they published this data, but I have to say, I've spoken to a lot of colleagues who haven't found this effect.
No.
So and I haven't seen it. So my judgment on that is open. I would my main use for rivastigmine would be mainly for the cognition or the cognitive aspect. If the gait is helped, that's fine. That would be my angle. I would not specifically go into treating gait problems with rivastigmine at this moment in time. But if you did, you have evidence to support it.
Thank you.
I just wanted one question, last question. What about the weight in Parkinson's disease? When they're more dyskinetic, when they're not so well controlled, the weight goes down. And when they're really well controlled, the weight is stable. And again, the DBS, post-DBS, weight gain is another issue as soon as the symptoms start getting controlled.
And sometimes the other way around also. You lose weight and then you start getting dyskinesia.
No, you lose weight is when your Parkinson's is not adequately controlled.
I think, again, Charu, very good question. So there is, again, very interesting literature. So Jagdish Sharma from Grantham here in the UK has published quite a bit on this low body weight olfactory dysfunction phenotype. According to him, there's a group of Parkinson patients who come with low body weight, and they also have hyposmia. These patients are actually more liable to dyskinesias. We have seen some patients like that. So they have pre-existing low body weight for whatever reason, and they seem to be more prone to dyskinesia, contrary to the common perception that we often see that you have a patient who get massive ballistic dyskinesias, which makes them lose weight. So both are true. On the other hand, we also see low body weight as a consequence of treatment. So DBS, as you pointed out, has been associated with an increase of weight in some patients, which is many people think is a resetting of the hypothalamic appetite axis and sometimes altering the appetite producing peptides in the brain. There's no direct evidence for it, but there is some animal model work to suggest that. On the other hand, we have seen levodopa infusion therapy causing progressive loss of weight, and there's quite a lot of literature on it. That seems to be due to the changing of the gut acidity because of the levodopa that's being delivered in a gel form into the duodenum, and development of SIBO, which is small intestinal bacterial overgrowth. So it's more a malnutrition related low vitamin B12 nutritional weight loss that you see with vitamin B, with levodopa infusion therapy. With DBS, the literature, or at least I'm not entirely sure we really know the cause, but the idea is this resetting of the hypothalamic appetite center. Add to this a specific small subgroup of patients, and I'll encourage all of us to look for it. People who are hyposmic, which is standard, as I've said previously in the MDSI webinar I did, we should all just do olfactory testing in every Parkinson's patient. It doesn't have to be formal testing, just even inquiry. Along with low body weight, that might mark this specific phenotype, which becomes another group where the risk of dyskinesia is even higher. So it's a very interesting area, and I think we need to do much more work on this in particular area.
Ray, do you advise dietary intervention for these people who are losing weight? So whether to add mass gainers and those, not whey protein, but the particular mass gainers that they have in these sports shops?
Yeah, I mean, I think that the dietary intervention where it really helps is, or nutritional intervention, is this levodopa infusion related weight loss, nutritional weight loss, or malnutrition, where probiotics have been found to be quite useful. Probiotics which penetrate into the large bowel or into the upper intestine and are not destroyed in the stomach. So in the UK, we use a probiotic called Sympt quite a bit. It's widely available. It's actually only online available, and the Sympt appears to be the only probiotic that we know, apart from I think one other, which has penetration into the duodenum, which is where you want, because that's where the absorption takes place. All the other probiotics that we buy over the counter, like the Yakults and others, get denatured in the stomach. So probiotic use might be very useful, particularly specific ones with large intestinal penetration. But again, there are trials ongoing now. Interestingly, Sympt is now being propagated as a treatment for irritable bowel syndrome and also for inflammatory bowel disorders. So there might be some truth in it.
Just a comment on Sudhir's this thing, whey protein might interfere with dopamine absorption.
Not whey protein. Mass gainer is different. Mass gainer is different. They have more carbohydrates. So it's for putting on weight.
Okay.
Whey protein is only protein.
Okay.
And again, it might be quite different. I mean, it's very difficult to generalize. I'm talking more from a white Caucasian perspective and our multi sort of ethnic population that we have. I think the Indian population, particularly the Parkinsonian population, might have a different gut sort of microbiota type reaction. I'm not totally familiar with that. Again, it's really something that needs to be studied.
Is the dyskinesia related to milligram per kilogram of the levodopa? You lose weight and the levodopa effect goes, or is it more than the percentage of weight loss that you have?
You mean in this low body weight phenotype?
Yes.
Yeah, that's not clearly established yet. I mean, I think it's quite a rare phenotype. I don't see them very often, but it is true that in these patients, you've got to be very closely observe their levodopa dosing. Now, it may be that they also might have a problem with their COMT enzyme, which breaks down levodopa. That has a high activity and a low activity allele. So if they have the H high activity allele, they're breaking down your effective dose of levodopa very quickly. Whereas these guys might have the low activity allele, which means the same dose of levodopa will last much longer in their bodies. So you've got to be very careful with the levodopa dosing. So it might have something to do with the BMI as well.
Siddharth, any other questions? You want?
No, I think Ray might also be a bit short on
I
time.
think so, yeah. I think that was a great talk, Ray. I must congratulate you.
Thank you very much. Thanks, Sharon.
I don't know how do you pronounce two other force, but this was like that. I mean, like the whole non-motor symptoms. Very good.
I mean, it's impossible to, but sleep and autonomic and all that, we can do it another time, because I think that needs, and some of the questions you've raised are really important ones, particularly with advanced therapies. Again, I think that's really, really important to
Yeah,
consider.
I think we'll have to address it.
Pain and breathlessness and lots of
Exactly, particularly now with COVID, I think
I think it does matter. Yeah. Great.
Thank you.
Thank you very much. Thank you. Thanks for inviting me.
Parkinson no longer belongs to movement disorders now.
No, it's non-movement.
Bye. Thank you.
Thank you.
Thank you very much. Bye-bye.
Not yours, Sudhir.
Bye.
Bye.